Well, thanks everybody for joining us today. This is Allie Orwig with the Indiana Rural Health Association. Got an excellent presentation for you today. Do just want to go over a couple quick housekeeping items. The first is that we are recording today's session, so if you're not able to join us the whole time, we will have a link up on our YouTube page soon. The next thing I want to say is you all are in listen-only mode today. So if you have any questions, we encourage you to use the Q&A and/or chat function to do that. You should be able to find those by hovering either at the top or bottom of your screen, depending on which view mode you're in. We will keep an eye on those as the presentation goes on. And Andrew, Autumn, and I can act as moderators, so you don't need to keep an eye on those. We're happy to watch those for you. And today we have Andrew Mitchell from MKM Architecture and Design. So I will just go ahead and turn it over to you, Andrew, and we'll do Q&A at the end.
Thank you. Thank you. Well, welcome. This is The Good Place. It's discussing a design approach to improve clinical outcomes for an older adult population. Just a little bit about MKM. We believe that well-being is essential for communities to thrive. That's why we work so hard to improve the culture of health with stakeholders across the care continuum. We are in the business of designing meaningful places. Within that care continuum lies our target markets, which are community health, outpatient care, acute care, and long-term care. And the way we approach our practice is by trying to understand the delicate balance between health and independence. So while we have experts at MKM in all of these quadrants of the care continuum, our interest is, as a group, is the journey through these experiences during the course of one's lifetime. And for us, our process is simple. This means that each project presents an opportunity to build a unique team around the specific needs of our clients, from mechanical and electrical engineering to landscape architects and medical equipment planners. We compile a distinctive team of experts that respond to the specific goals and vision for each project. So today, discussing The Good Place, we have 3 learning objectives, and they're as follows. First, to explore the needs of older adults and caregivers in acute care, specifically examining clinical studies and underlying causes for current clinical outcomes of our aging population. The second is to analyze barriers and safety issues in current care settings, review the differences in clinical settings between older adults and other patients, and this includes some clinical practices for care. But I will preface this that I'm not a clinician, I'm an architect, so I'm an eager observer, and any of the clinical models that I'm presenting today are based on research papers and other documents prepared by clinical staff. And third, we're going to review some evidence-based solutions that promote positive outcomes. And we'll provide some case studies explaining interventions on several scales that promote positive patient outcomes. So this includes everything from brand new facilities to existing facilities, maybe aging facilities, that there's some strategies that you can implement to provide better care for aging individuals. So as we frame the issues and look at an aging population, we're going to focus on Indiana. As I'm sure you're aware, Indiana is aging, and from 2015 to 2040, Indiana's population is going to grow approximately by 15%. Of that growth, the population that will be 65 and older will increase by 90%. And as our population ages, the prevalence of chronic disease increases. And in most cases, these patients often have more than one chronic disease that they are managing. And this chart just shows just a brief view of that. So in the US, hospital admissions of patients 65 and older is approximately 40%. So of all the total admissions, 40% are 65 and older. But in rural settings, we're seeing more between 70 and 80%. So it's more of a bigger push on our rural facilities than you would see in urban areas. So with that, the research has shown that our current clinical environments are causing as much harm to older adults as the acute illnesses or injury that are cause for their hospital admission. And it's been termed hospital associated disability. And this study has been around for a few decades. And hospitalization associated disability occurs in approximately 1/3 of patients older than 70 years of age. The patients over 65 are less resilient during a hospital stint than younger patients. They are more vulnerable to mental and physical deterioration, even if they recover from the illness or injury that sent them there. And HAD, which I'm going to abbreviate because saying hospital associated disability is a mouthful, HAD has a poor prognosis. And a study of patients with HAD, within their first year, it had a mortality rate of 41%. And over 29% remained disabled at 1 year, and only 30% returned to their pre-illness level of function. So there are several reasons for this, and we'll dive into that as we get further along. This disability can result in the need for additional help in the home or even admission to a skilled nursing facility. And according to CMS, total U.S. healthcare spending was approximately $3.6 trillion in 2019. Of that $3.6 trillion, $750 billion was dedicated specifically to Medicare spending. And of that, $57 billion was the current spending for post-acute care services, including rehab through home health, inpatient rehab, and skilled nursing. So with these statistics, what's the root causes of HAD and how it may be obvious to, directly disabling illnesses and injuries such as a hip fracture or a stroke can lead to long-term disability. It's less obvious how other illnesses can lead able adults to develop lasting disability while recovering in the hospital. According to the research, age is the most potent risk factor. However, other contributing factors to development of hospitalization-associated disability exist in the environment of care. And we're going to review some areas where facilities may create a barrier to recovery for aging adults. First one of these is in regard to mobility, and this seems to be the most obvious. Most hospitalized older adults spend the majority of the time in bed. Hospital patients are often inadvertently restricted in their movements because of tethers to medical gas outlets, IV poles, other equipment. And in older facilities, the patient rooms aren't designed to minimize risk of patient movement to support services, whether it's a bathroom or a side chair, anything that would promote movement. And we also see bed rest restrictions just to minimize fall risks as a means to mitigate additional injury. But because of low mobility, we're seeing a higher prevalence of HAD in patients 65 and older. Sound is another issue that we're looking at as far as a factor of HAD. Hospitals are noisy places, and while there's been a greater effort to manage the sources of sound within a hospital, whether it's quiet hours or isolating units from non-essential personnel, most facilities are not designed to manage all the environmental noises that you have within a hospital. And depending on the age of the facility, the built elements of the hospital itself often counteract any quiet noise reducing methods just because of hard surfaces, poor insulation. And excessive sound disrupts the patient's ability to sleep, which can cause day-night sleep reversal, increase anxiety. It also leads to disorientation and confusion for patients who have cognitive issues. Looking at this further, equipment noise and alarms, again, are a persistent problem. Multiple wellness checks within the room can disrupt sleep. Most corridor walls, again, are not designed to prevent the environmental noises from permeating into the patient room. And the updated facility guidelines for hospitals, which has been adopted in Indiana, require improved noise and sound isolation for patient well-being and for staff work areas. So as we update our facilities, some of these issues will be remedied, but not as quickly as it needs. Tertiary noise from nurse stations or other clinical support areas can be hotspots for sound pollution. Again, the facility guidelines require improved noise and sound isolation for our medication dispensing areas and clinical documentation areas. So not only is it helping improve the patient experience while they're in the hospital, but also provides better work areas for the clinical teams to focus without disruption. And while most of the common remedies focus on noise canceling properties of walls, impact noise from floors above the patient care areas are also a common source of sound pollution. Hospital finishes are often selected for durability and ease of cleaning, and these systems often have poor sound absorption properties. Another barrier to recovery is wayfinding within the facility. Support areas for patient care are not concentrated and discourage patient mobility, requiring use of different types of patient transport, whether it's wheelchairs or beds or patient carts. Few orientation cues also lead to patient disorientation and confusion. With an aging population and trying to maintain, keep them ambulatory, the ability for the patient to be able to walk from one point to the other is important in their recovery. And because of the dispersed nature of hospitals, getting from A to B is often difficult because of whether you're crossing public corridors or if you're trying to navigate through disparate units. And signage and material patterns, which while they seem very simple, aren't often interconnected. So you don't have a cohesive way to communicate how to get to the desired location. Again, we discussed it a little bit with sound, but monolithic solid flooring surfaces increase the likelihood of falls with aging patients. And again, this often leads to bed rest orders that limit ambulation and increase risk factors that increase the prevalence of HAD. There was also a study that noted that shiny surfaces, I'm not quite sure how shiny the surfaces had to be, but shiny surfaces actually caused confusion amongst patients with cognitive issues, which led to an increased rate of falls. And finally, social isolation is another barrier to recovery and one of the leading contributors to HAD. Often meals are served in the patient room. Patients are eating by themselves within the bed. Sometimes they transfer to a side chair, but the lack of interaction, and meals are a social event, the lack of interaction with peers increases the likelihood of depression and cognitive dysfunction. And while given our current environment of COVID, this may be rethought, and other methods to address this may be coming to the forefront. Interacting with your peer group is important to maintain your mental function. And this is some of the research that we've put together at MKM. It shows, 30 lonely people are 30% more likely to suffer from a stroke or heart disease, and it's actually a physical reaction to loneliness. And it's based on a Harvard study that showed that loneliness, someone having no friends, was linked to an increased level of blood clotting protein, which can cause heart attacks and strokes. So how can we improve outcomes? And what methods can we use to address these issues within our facilities? And so we looked at a number of methods, and the research has shown that the strongest evidence that redesigned care systems improve outcomes stems from Acute Care for Elders Unit, or ACE, another acronym. These reduce the incidence of functional decline at discharge and reduce the hospital length of stay. They can also reduce the reduction in hospital length of stay results in cost savings that are often greater than the added cost of the unit. A recent study looked at ACE units and the prevalence of 30-day readmissions, and found that ACE units reduced the length of stay by at least a day, and reduced the prevalence of 30-day readmissions by up to 40%. The ACE unit itself is not necessarily an isolated unit. In fact, most often they are located within an existing medical surgical unit. This example is a 6-bed ACE unit within a 33-bed med-surg telemetry unit. This unit is staffed by a clinical team with a focus on care for aging adults. So the clinical team has some specialization for geriatric or aging individuals. And this unit specifically was configured in a 6-bed semicircular pattern, providing an optimal layout that included proximity to the medication room, to unit supplies, and increase the line of sight views into all the rooms from the nurse station and support areas. The clustering of these rooms in the corner, if you will, also allows a quiet environment away from the activity of the nurse's station, but also the adjacent clinical spaces. And within this unit, aside from the clustering of these individuals, the patient rooms are fairly similar to the rest of the unit itself. The staffing model for this unit consisted of a nurse-patient ratio of 1 RN for 5 med-surg patients or 4 telemetry patients, depending on the overall patient acuity. For this ACE unit, the staffing pattern consisted of 2 RNs, one caring for 4 patients and the other caring for 2 patients within the unit. And then that RN also cared for 2 additional patients on the med-surg unit that were within close proximity of the ACE unit. This study also looked at the facility added a CNA to focus and coordinate care for all 6 patients. And the staffing and unit configuration optimizes the care coordination among the 3 primary caregivers at all times. Within ACE units, the clinical team meets daily, as you would typically see on a med-surg unit, but they're also charting various health outcomes that I don't know if are as common for a what I'll call a standard med-surg patient. The focus of the ACE unit is to be able to discharge the patient at home. And the definition of hospital-associated disability, and I think I might have glossed over that a little bit, is, it manifests as the loss of the ability to complete one of the basic ADLs needed to live independently without assistance, whether that's bathing, dressing, rising from a bed or a chair, or using the toilet, eating, or walking across the room. So these ACE units are looking for ways to reinforce therapies to improve the loss of the ADL. And so by doing that, they're also looking at barriers to completing that test. So each day, the patient's evaluated for whether they need to be either on medical gas, so oxygen, if they're connected to a med gas outlet in the wall with a cannula, or is it a portable tank? Well, it's still a portable tank, still a tether. The use of catheters is low amongst ACE units just because they are another tether. The clinical teams promote safe ambulation. By doing that, they all the meals for these patients are in a separate area. It's typically a common dining area or several common areas, depending on how the facility approaches infection prevention. So the patients are getting up to move to get to their dining area. And then in addition to that, and some similarities to skilled nursing, if you've seen some of the correlation, but there are means to try to get these patients to mimic most activities of their daily life as they recover from their illness. Now, there are some limitations based on their illness, but for the most part, these units are focused on reinforcing skills and systems to promote discharge to home, as opposed to discharge to rehab or discharge to skilled nursing. Within the ACE unit, and this room is different from this patient room. This room's a better example of some of the key elements that an ACE unit room really hits on. The first one being the patient bed. Most patient beds are raised up. They have a high barrier. So if the patient is trying to swing out from the bed, dropping down off the bed is a hindrance. So to promote a safe environment, ACE units provide low beds with exit alarms. Again, they're still promoting safe movement within the facility. So they're looking at clinicians to provide assistance, whether it's with access to assistive devices within the patient room or the availability of physical therapy services. The patient toilet is readily accessible. To get out of your bed to move to the patient toilet, there is a continuous grab bar that leads to the toilet. The toilets are raised, either raised toilets or raised seats, grab bars in all bathrooms, but again, that's a given with most accessibility. Supplies are in close proximity to promote caregiver presence and constant observation. Ease of access to a side chair. Ease of access to a side chair is provided. In this case, for this facility, They're showing a side couch that also folds out into a bed. In most ACE units, the clinical teams promote that are really encourage loved ones to stay as much as they can with with the patient while they recover. Again, getting into means to mitigate social isolation and looking at the research for recovery. In this case, with this patient room, it's showing a fold-out bed, but in some ACE units, we are seeing additional beds, whether it's another hospital bed or if it's just a folding portable bed that you would see in a hotel, brought alongside the patient bed on the family side of the room, just to promote that need for social interaction and to improve recovery. Within this room, you also see a couple other elements that aren't as obvious. The flooring material, in this case, it's a softer material. Some ACE units are starting to look at the use of carpet. I'm not sure I'm as convinced that that's the best product, but with carpet, it does have an antibacterial backing. So if you have any questions about infection prevention, we can share some literature on that. But the carpet helps mitigate sound. So it's absorptive and you don't have any issues with dead loads from the floors above. It has a nice view of an area of respite. It also has a sliding door to ease of access. So whether it's a lever handle or a sliding door, this allows for a better patient movement. Back to the carpet. Carpet also is a better surface for movement with patients who have some mobility issues. So we've seen that in some of our long-term care and skilled nursing facilities. But again, not quite sure about carpet in a acute care environment. And I'm sure we've got some other attendees who probably have a similar thought. The ACE unit for staff also is not only are they looking at patient outcomes, but they're also looking at the outcomes for staff, specifically in regard to burnout. The clinical staff within ACE units have increased satisfaction, especially among nurses and physicians. And many of the processes adopted by ACE units are also facilitated by a group called Nurses Improving Care for Health System Elders, or NICHE. And this program provides resources to nurses to improve the care of hospitalized older adults, but also helps with strategies to avoid burnout, to promote collaboration amongst the clinical teams, and look at best practices. Specifically, as I discussed previously, the encouraging mobility and developing protocols to focus on safe mobility to avoid falls. So with that, IV and catheter use for the patients are evaluated each day, and they're removed when deemed necessary by the clinical team. And a little bit more about NICHE. It's an international nursing education and consultation program. It's a program of it's an international program, but the New York University Rory Myers College of Nursing provides resources through NICHE for nursing staff and interdisciplinary teams to achieve organizational goals for the care of older adult clients. Today, NICHE is a leader in geriatric care, and the network of healthcare organizations that are NICHE accredited is over 500. In Indiana, we actually have 6 facilities that have met the requirements to be certified as senior friendly by niche. And these facilities are specifically focused on recognizing hearing loss, vision, falls, gait, and balance issues. They have demonstrated their focus on improving clinical outcomes for aging individuals. And they also provide extra sensitivity when providing care to these individuals. They implement proven strategies and methods to address specific issues pertaining to aging adults. And they include families in care plan development and execution, which is, I think, something that we see elsewhere within our facilities, but this is definitely focused more on transition and how to reinforce best practices to improve the outcomes for loved ones. They enhance overall patient and family experience and have demonstrated that consistently, and they stimulate culture change within their facility to achieve patient-centered care, which I think and that's what I see as kind of the evolution of niche is not only just a focus on older adults, but how can these strategies and methods be applied to the rest of the hospital so that the entire facility focuses on a patient-centered care that improves clinical outcomes. So we're going to look at some case studies, and one thing when researching ACE units, the literature is plentiful, but the graphic examples are few and far between, and that's actually for a couple of reasons. And this first case study, which is the Royal Jubilee Hospital, which is in Vancouver, British Columbia, it was at the forefront of a reimagined hospital for people of all ages and abilities. Something that we've studied quite a bit at MKM, most on the community health level. But with this facility, they were looking specifically at, if we design for the most vulnerable population, that improves the outcome, should improve the outcome for the rest of the patients who come to our hospital. So they were among the first to create an elder-friendly acute care hospital to support its goal to become a center for excellence in seniors care. Now, the reason you don't see many of these cases is that we aren't seeing as many facilities dedicate their entire facility for elder care. So with some of the case studies to follow, we'll show what I call interventions, where they modify some part of a patient floor to meet some of the programmatic requirements that we've discussed for an ACE unit. And with that, they're still meeting the care requirements for others within the facility. So within this first example, they created an elder-friendly hospital that resulted in a facility that is universally accessible by considering the psychological changes that occur with aging, and by designing an environment that is responsive and complementary to these. The built form inherently becomes safer and more responsive to the needs of anyone who has cognitive or physical vulnerabilities, whether this vulnerability occurs as a result of an accident, illness, or medical intervention, and regardless of age. So within their units, you see pods of 4 on either side of a double-loaded corridor, and at the end of each pod is a common area for activities, but also for patient dining and for other programmed use. It's kind of interesting how by a curved floor plan, which also helps accent and frame views of vistas and other scenic landscapes, they're also able to create wayfinding within the unit, so that at the changes in the floor plan is where the activities occur. Here's some photos of their facility. And as you can see, their patient room looks like a fairly standard patient room. Nowhere in this image does it scream, this is where the ACE unit exists. And I think that's partially because there's still a clinical component that's required to help recover from the initial reason that the patient was admitted to the hospital. And the processes that are part of the ACE unit are help to prevent hospitalization associated disease from occurring in the hospital. Again, I'll point out that they are using a hard surface for flooring. And other than that, it's a fairly standard patient room, where I think you see that the nuance is in some of the common spaces, whether it's the common area around the nurse station or an open common area for dining. You see it looks like a lounge or a library that you would typically see in a long-term care or a skilled nursing facility. There's also different types of seating, whether and based on our research, the seating is also based upon the level of recovery for the patient. So as the patients improve in mobility and function, they are accessing different levels of dining. And again, having improved circulation and wayfinding, signage, but also using the architecture to drive movement through the facility. And some other items they're using color to highlight the contrast between edge of floors and walls. They're also using color to disguise out of bounds or back of house spaces. One thing that is not, and you can see it a little bit in the lower right image, but their public common areas also interconnect with areas of respite outside within gardens. Those are accessible with the assistance of caregivers. This facility also has a universal floor plate across the various inpatient services that promotes familiarity and wayfinding via repetition. This is a quiet hospital. It does not use overhead paging or has a nurse call system that is audible unit-wide. And they're using technology to be able to keep with the clinical requirements of notifying the care team when the patient needs assistance, but also by using that technology, they're not creating a disturbance for other patients who are not affected by that need. One thing, and this patient room shot doesn't quite show it, but in all of the patient rooms, they are designed with family zones with either a fold-out couch or the ability to roll in a patient bed for the family member. So how to implement some of these strategies within your facility. And we talked about this a little bit when we first looked at this initial ACE study. And most facilities have a floor plate that has similar characteristics, whether it's isolating a few rooms. And now, given within a rural context, whether you're talking a critical access hospital or a facility that's looking at minimizing FTEs, you're not going to create a disparate unit separate from other patient care areas just for the sake of creating an ACE unit. I don't think that's the focus here. With these units themselves, they are meant to be placed within a clinical area so that there is some overlap of care, but also they tend to be incubators for best practices that continue on throughout the rest of the hospital, whether it's within the med surg unit or other similar acuities. The sound qualities of a patient room, which again also can apply to other patient rooms, there are easy strategies to implement, whether it's a policy to prevent different types of audible alarms from ringing throughout the house, or ACE units are really focused on the duration of sleep that the patients receive. So less periodic well checks throughout the evening so that the patients receive a longer duration of sleep. And I know some facilities are adopting some of these practices just because they make sense from a wellness standpoint. But it's funny how some of the simpler items that you can implement are not always the most obvious. The use of patient furniture or medical equipment that promote ease of movement is another effective strategy to bring in. I'm not saying remodel the entire room, but if you can change out the type of patient bed that allows a low access so that the patients can get up and move, not necessarily down the hall to a separate area, but even just from their bed to a side chair, makes an incredible amount of difference within the statistics for recovery for that patient, especially given the prevalence of HAD. Your patient toilets, I'm assuming you're not going to go through and remodel your patient room, especially if you have an outboard toilet and it's across the room. No, but are there other strategies that you can use to help increase the assistance or to minimize the assistance required for patients to use the patient toilet? Again, trying to get patients up and move around. We've worked with facilities where they've actually provided mobile equipment so that supplies are easily brought to the patient care area so that the clinical teams are interacting with the patients as they are caring for them each day. Finishes are an easy way to improve quality. That even though I'm not ready to recommend carpet, there are other solid surface materials that provide some sound reduction qualities that are easy to bring in and to trial as a way to improve or reduce sound pollution. And here's an example of a project that MKM was involved with. This was on a typical med-surg floor. The rooms were, and you can actually see this dining room actually is what it became, was actually a former patient room. So you have the head wall. I don't know if you can see my cursor, but you have the head wall, which is planned south. So an easy route to get from the patient bed into the patient toilet. So we had all the inpatient rooms had met that requirement. The facility had updated, and this is a niche certified facility, just for your reference. The facility had changed out their equipment, patient beds, so that they all promote patient mobility. They encouraged, and they had a checklist each day that they included with the patient. The patient was part of the care team. So they gave them a clipboard and a stethoscope, but they were part of the care team. So they had a checklist each day of different ADLs that they had to try to complete. And so movement from the bed to the side chair was another one. So one of the items that was missing from their med-surg floor, without making a lot of changes to the patient room, was a common dining area. And with this facility, it's not necessarily dining with other patients because of their infection prevention protocols. They were not going to promote that, but they wanted what they called a family lounge. So it's a place for family or friends to come and to dine with their loved one while they were recovering. That was part of their ACE unit. And it was within walking distance of the rooms that they designated as their ACE unit. And it's become a model that they were looking to implement pre-COVID elsewhere within their facility because it had become successful. So not only were they looking at this from a med surg standpoint, but from a labor and delivery in their recovery unit, could they create a family lounge that allowed family members to dine with the mother and the father and the infant child? But this again, it's a really simple intervention, and it doesn't necessarily have to be a patient room. It could be some excess space that we can engage a design team to figure out how can I create a dining area within my facility to support and improve patient care. This is some research that framed our presentation as well as some websites that are very helpful. Hospital Elder Life Program is a good resource, as well as GeriPal. One of the things that we really glossed over in this presentation was most ACE units really have a rigorous assessment that they apply to patients before they are accepted into the ACE unit. And with that, they determine whether there are pre-existing conditions that exist that would prohibit the patient from recovering and completing most of their ADLs. However, I think that there's been some research that has positioned this as, this is cherry picking. You're picking the best patients so that you have the best outcomes. However, some of the initial clinicians who have researched have studied this and found that no, you need this rigorous assessment because it's not a good clinical outcome if you're trying to promote mobility with someone who's had chronic mobility issues for most of their life. They don't have that ADL to begin with. So with that said, I think we've got a few minutes for questions. I don't know if anyone has any questions to bring up. I apologize if I went through this fairly quickly.
Okay, we've given it a little bit of time here. I'm not seeing any questions in the chat or the Q&A section. Let's see here. No, I don't see any questions that have come in here, Andrew. We have shared a SurveyMonkey link for all of our attendees today. Whether you've attended live or via our YouTube, we do hope that you will take the time to follow up with that post survey. Literally takes less than 60 seconds. If you do have any questions, I am confident that MKM is always there and willing to answer anything you might have wanted some more information about. And you can see their website is right there. They've been a long time supporter of IRHA, and we often see them at our annual conference and other events. So that's always a place that you can interact with them. If you haven't come up with a question today, I'm sure they're happy to answer any questions in person when you see them.
Yes.
So we do just want to, go ahead.
Oh, yeah, I just wanted to say, our website also has white papers and other research on some of the other topics that we've been studying over the years. So my contact information is available through the website. Please feel free to check it out.
Okay, well, we really appreciate everybody's time today, especially yours, Andrew. Great presentation. Again, we have recorded today's session. It will be available via our YouTube channel soon. You can get there by searching Indiana RHA on YouTube, or you can just go to our website, which is indianaruralhealth.org, and you can go to our archived website or our archived webinars there anytime. So thanks